As part of our third-year residents have to do a ground round of their choice, trying to indicate us about a new field that they choose, and I think Dr. Moore is chosen food allergies to talk to us about. I personally worked with Dr. Moore multiple times. She's a very smart resident, and I'm looking forward to this presentation. So go ahead.
Thank you, Dr. Kailani. Can you guys hear me? Okay. So I chose food allergy. I've been doing a lot of allergy and immunology this month, and I feel that it's one thing that as general pediatricians we are not very confident or competent in. It's a very broad topic, so bear with me as I try to narrow it down to be more directed to the general pediatricians. So I have no disclosures. My general objectives are to identify immune and the non-immune food mediated food reactions, to define food allergy and discuss how it's managed, illustrate the impact of food allergy on life, and differentiate various adverse food reactions from food allergies. So this is just a little diagram to depict your immune mediated from your non-immune mediated, and then your immune mediated can be divided into two different categories as well. Your IgE directed and your non-IgE mediated. Food allergy in itself is actually IgE immune mediated, whereas the other ones that are listed below, celiac disease, the food protein enterocolitis, and the eosinophilic enteritis are non-IgE. And I'll go through a little bit of these, but again, like I said earlier, I'm going to focus more predominantly on the food allergy. And then your non-immune mediated are a wide variety. Your enzyme deficiencies like your G6PD deficiency, GERD, malabsorption specifically in like cystic fibrosis, your pharmacologic causes like with your clindamycin, your azithromycins that cause the GI symptoms, psychological, so this made me think more of Dr. Herbst with his anxiety-producing GI symptoms when he asked, are you the member of the Sweaty Palms Committee? Food poisoning, toxic reactions, and then lactose intolerance. They're all part of non-immune mediated. So again, I'm going to focus more on IgE and food allergy. So what is food allergy? It's an immunologically mediated adverse reaction to a food. And so what happens is your food-specific IgE actually binds to the GI mast cells and the serum basophils, and it causes histamine and tryptase release. And those then travel through the gut system, and that's how you can get systemic reactions from ingesting a food substance. So again, the adverse food reactions, now we're going to talk more specifically on the immune-mediated food reactions. So the immune-mediated food reactions are your gluten sensitivity or your celiac disease, food allergy in itself, eosinophilic esophagitis, and food protein enterocolitis. And I'll talk a little bit about these, like I said before, but not too detailed. So your top 8 food allergens are, with children, it's your cow's milk, your egg, your wheat, your soy, and your peanuts. And then with adults, it's your tree nuts, your fish, your shellfish, and your peanuts as well. There are over 170 foods that are actually documented in cases of food allergies, but these are your top 8. These are your big dogs that most people will have reactions to. As it says there, about 90% of all food allergies are composed of these 8 food groups. So what causes a food allergy? Food is actually composed of various different substances, as we all know. We all went through med school, and it's composed of your proteins, your carbohydrates, and your fats. So your protein is actually your cause for the allergic reactions. Carbohydrates, it's very uncommon, and fats is essentially very rare for you to have an allergic reaction. So the other thing is the protein can be transmitted not only by ingestion for your GI symptoms, but it can be inhaled, or you can actually have absorption through your skin. So with inhalation, typically if you're allergic by ingesting the food substance, you may also react by inhalation. So if someone's cooking something in the kitchen and there's the particles or even the smell itself, they can have an adverse food reaction or the allergy. Asthma is a very strong predisposing factor, and the symptoms may only be respiratory-wise because of the inhalation. It may be multisystem, or you can even have anaphylaxis because of inhaling the food protein. Symptoms typically involve nasal, ocular, or lower respiratory tract, as mentioned here, and so they may think that it's just a little bit of a seasonal allergy and not really relate it to a food allergy by inhalation. The treatment is just avoiding it. With all food allergies, I'll stress over and over again that the main treatment is strict avoidance of that food substance. And if they have any symptoms, any near symptoms of anaphylaxis, you want to use epinephrine and then wear a medic alert so that other people will be able to be aware that you're allergic to that food substance. As far as skin goes, it can either be a food allergy based on irritant or an immunologic reaction. So you may have just a little bit of a contact dermatitis, or your contact dermatitis may be even more prominent. Some people actually get a little bit of contact dermatitis and it's not aware until they go out to the sunlight and they have the phototoxic contact dermatitis. There may be a delayed reaction. It may take a few minutes, a few hours, or even days after exposure to that substance to their skin. And as well as the skin symptoms, they may also have respiratory or anaphylaxis through absorption from the skin. And atopic diseases like your atopic dermatitis, they may have more of a localized reaction or a systemic reaction, especially if they have any open lesions in their skin. The most common cause of food allergies through absorption of the skin are eggs, milk, fish, and peanut butter. These are just some other examples of allergies in foods that are absorbed through the skin. So there's raw foods, your fruits and your vegetables. There's additives. The things that I was thinking about with additives were your dyes and your emulsifiers, things that people don't usually think of. And the additives are actually related in atopic individuals in about 2 to 7% of those atopic individuals. The epidemiology of food allergy is very broad, so I wanted to, again, limit it down and focus it more towards the general pediatrician. So 8% of all children less than 6 years old actually have food allergies, and only 1 to 2% of the general population has documented food allergies. Approximately 25% of the general population thinks they have an adverse food reaction, but only 1 to 2% is documented and proven. 80% of children will have a food allergy within the first year of life, and 50 to 90% of all presumed food allergies are not indeed allergies. The most common in children is typically your cow's milk, your soy, and your egg, as I mentioned earlier with that little diagram of the circles. But the most common, the number one in children, is your cow's milk. 90% of those individuals allergic to the cow's milk are also allergic to goat's milk. So typically we relate the cow's milk more to soy, and I'll talk about that later on, but it's also a cross-reactivity with goat's milk. And the second most common is egg. Food allergy is more common in infants and younger children. It's due to the sensitization and other details, but 90% of those individuals with a milk allergy will actually grow out of it by age 5. Some grow out of it even by 1 or 2 years old. Others will grow out of it a little bit later on. And I'll talk about that as well later on. Genetics is actually another topic that is related to food allergy. Most people don't really think that if a parent has a food allergy, you're more susceptible to developing one, but there's a correlation between atopic diseases and genetic predisposition to have food allergies. And so it shows here that if both parents have the exact same atopic disease, whether it's a food allergy or asthma or eczema, then the offspring has that 72% risk. And as mentioned, once they vary or it's down the kind of totem pole or hierarchy in the family tree, then your risk decreases, but it's still there. Prognosis for children with food allergies, it varies on several different factors. The younger you are when you develop your food allergy, the more likely you are to outgrow it. The type of food is very important. You're more likely to outgrow a milk allergy than a peanut allergy. And if it's more of a severe reaction versus a mild reaction, those with mild reactions are more likely to outgrow their food allergy as opposed to the severe reactions. As mentioned earlier, atopic diseases are a huge factor in food allergies. Those include asthma, your allergic rhinitis, as well as your atopic dermatitis. If you have atopy and multiple food allergies, you're less likely to outgrow food allergy as well. If your symptoms of what I typically think of are your atopic dermatitis, if your symptoms are very poorly controlled or they're very severe, you're having to admit that child to the hospital, or you've tried all types of topical steroids, plus you've put them on anti-itch, antihistamines, and they're still having to come back frequently because of these flares, then you really need to consider sending them to allergy and immunology and testing them for a food allergy, because we may be missing something that's not only in the environment, but they're also consuming, that's causing all these flares. So Dr. Bana gave me a few journal articles, and one of them was by the NIAID, the National Institute of Allergy and Infectious Disease, and they composed guidelines for food allergy. And of those guidelines, the expert panel they placed wrote all these suggestions. And they said that if for any child that's less than 5 years old with moderate to severe atopic dermatitis, consider the food allergies for milk, egg, peanut, wheat, and soy. If either of these below exist, so you have your persistent atopic dermatitis in spite of your optimized management and treatment, or they have a history of an immediate reaction after ingestion of a specific food. So if they can pinpoint that that food caused this reaction, then you need to test them for food allergies. There are tons of studies throughout medicine on atopic allergenic foods, among other things, and I'll touch on those as well. But one study in particular tested 6,905 children over a 4-year span for the correlation of tree nuts and wheezing. And that one actually showed that there was a significant association, but if you read the next 3 lines, it actually shows some confounding factors. So it doesn't really support that there is an association. And then the next study showed that introduction of cow's milk, eggs, peanuts, and then your tree nuts, again, like mentioned before 6 months old, there was no significant association. And so finding studies and participating in studies that actually show a good correlation between the symptoms and an associated food introduction is very difficult, and most studies actually show that it's very inconclusive. And so we need to continue performing those studies and doing research. So this is just one case to introduce us into the next topic. 3-month-old male fed commercial baby formula presents with irritability associated with feedings. So what's your diagnosis? Is it milk allergy, reflux, lactose intolerance, colic, or not related to food at all? And I'm not going to wait for answers, I'll just continue. The point of this case is to show you that with the baby formula, the irritability associated with feedings, and the age, it could be any of these above. It doesn't have to be one in particular. We're not, placed with a crystal ball. We can't look into it and automatically assume what's the cause. So we need to go into more details. So you need to ask very detailed history to the patient or parents or grandparents. You need to perform a very detailed physical exam, and you need to consider doing any testing, whether it be laboratory testing or food allergy testing. So for diagnosis, I'm going to stress more on history and physical and allergy testing, but I also wanted to tell you about the elimination diets and the food challenge. So elimination diets, if you suspect that there is a food allergy, then you want to talk about the symptoms, discuss avoiding that food, and if it resolves, then that's your elimination diet. A lot of parents will actually come into our offices and tell us, oh yeah, I just took it out and all the symptoms resolved. But then we run into the fact that they're too worried to retry that food. And so you have to educate them on that, and we'll go over that as well. And then with food challenges, this is to be performed with an experienced clinician, preferably allergy and immunologist, where they can actually monitor the patient for a designated amount of time to evaluate for any signs or symptoms of foods once they introduce them to that patient. And it's a double-blind, placebo-controlled study. So with history, you predominantly want to discuss the symptoms. So are they IgE symptoms or are they non-IgE symptoms? With your IgE symptoms, as mentioned over and over again, that's your food allergy. With your non-IgE symptoms, Those are typically your GI symptoms. So these are your enterocolitis, your celiac disease, so they're more GI related. And they can recur or be chronic. So to talk about your IgE symptoms, they can present with skin symptoms, with respiratory symptoms, or GI symptoms. They can even present with anaphylaxis. So examples of skin symptoms are your dermatitis, your eczema, urticaria, skin dryness, pruritus, and flushing. Respiratory symptoms, as most of us have either witnessed or discussed with patients, are your difficulty breathing, your wheezing, your what they describe as a throat tightness, like their glands are swelling in, nasal congestion, or even your laryngeal edema. And the respiratory symptoms are more common with your environmental allergies, your pollens, your molds, but they can also, as mentioned earlier, with your inhalation of the food proteins, present with respiratory symptoms. Then your GI symptoms can be just regurg, it can be gas, it could be abdominal distension, cramping, nausea, vomiting, and diarrhea. It could be bloody or fatty or neither. And your GI symptoms are your most common because foods are typically ingested. And then your anaphylactic shock, which we'll go over also. As far as your physical exam goes, obviously it's going to be a generalized exam. Anytime you see a patient, we typically do a very thorough exam, especially if they're going to present with any signs of atopy or food allergy. But you predominantly want to focus on the systems in which they're going to present with symptoms, so your skin, your respiratory tract, and your GI tract. You also want to go over a food diary with the patients and the parents. This can oftentimes be very difficult because some have a difficult time being historians, but if it helps, do what like we do with headache diaries. Send them home with a piece of paper, tell them to write down everything that they eat, breakfast, lunch, and dinner, if they cooked it, if they didn't cook it, all of those details you want to talk about. You also want to talk about what foods have they eaten. If it's an infant, are we breastfeeding? Are we on solids? Are we doing formula? What type of formula? When did we start doing formula? What's our history of breastfeeding? When did we transition? As far as timing goes, what's the timing between the ingestion of the food? Did it take minutes? Did it take hours? Or did it take days for the allergy or the symptoms to develop? Are they GI symptoms? Are they non-GI symptoms? Or are they both? What's the reproducibility of those symptoms? Does it happen every time they eat the food, or is it absent if they avoid the food? What's the quantity of the food triggering the symptoms? Does it take just a few drops? Was it inhalation? Was it a large amount? And what's the progression over time? Is it getting worse? Is it better? And then with diagnostics, once you get the history and the physical and you say, you know, it's a very strong possibility that this is indeed a food allergy, then we can test for that. Typically we don't do that in a general pediatrician's office, so we would do that in an allergy and immunologist office. And what they can do is either a skin prick test or a serum antibody test, which we usually see in the media section as we're asked, which is your IgE testing. The skin prick test has a positive predictive value of 50% and a negative predictive value of 95%. What they actually do is they take the food extract, and it's in a little diluted solution, and they take it with somewhat like a needle, and they place it on the skin and they prick the skin so that you have more of a direct contact with that food extract. Then they wait a designated time. Our allergy and immunologist fellows typically wait about 15 minutes, and then they go back and reassess the area that they've placed the skin test. And they'll measure the size of the wheals. They'll grade it from 0 to 5, 0 being that there was absolutely no reaction, and 5 being the most severe or strong reaction. This is typically the fastest test to verify food allergy. It's very accurate, but it's very technique dependent, and it requires cooperation. Luckily, there's vials and tools to where you can actually place multiple different food items at one time, especially when you're considering testing this on a 6-month-old or 15-month-old that doesn't want to have something sharp stabbed into their back, even if it's just for half a second. It's also not valid if there's any antihistamine use within the past 7 days. And so once we send our patients to our food allergist, we obviously want to put them on an antihistamine, especially if there's any pruritus, and to reduce any other inflammation. but once they go to the food allergist, they won't be able to have their skin testing that day. And it's not something that we should have to worry about. The allergy and immunologist will get even a better history, and then they'll discuss repeating this test or performing this test at a later date. But that's just something for us to consider as well. The IgE testing is your most sensitive test. It's accurate. It doesn't have any interaction with your antihistamines, but it's lab dependent. So if your lab doesn't have the test, you have to send it out. There's a waiting time period, or if they lose the sample, there's multiple things that can happen. Here's another case. So a 14-year-old with a history of severe anaphylaxis to peanuts 15 months ago ate a peanut 5 minutes ago and is asymptomatic. So what should he do? Should he just go ahead and do epinephrine and call 911? Should he just do Benadryl and albuterol now and prepare for epinephrine, or just observe for signs and reactions, then take the meds if needed? So the problem is he has a known reaction with peanuts, anaphylaxis in the past. So epinephrine should be used as soon as possible. You don't want to delay even before the symptoms present. If there are milder measures like Benadryl, then those can actually mask any further signs and symptoms of anaphylaxis. And so you want to go ahead and treat right away, especially with the history. So with treatment, like I said before, the number one is avoidance. So you want to avoid whatever food substance you suspect for a food allergy. You want to make sure that they have identification to alert anyone else outside that they have a food allergy. And with epinephrine, we typically, as pediatricians, have been known to prescribe 1 EpiPen with a refill, but what we should really be doing is providing 2 EpiPens, because 18 to 35% of anaphylactic food allergies actually need that second dose. And anaphylactic reactions may be prolonged or biphasic, so you want to make sure that they are provided with 2 doses of epinephrine if needed, and as soon as they administer that epinephrine, they need to call 911 and seek emergency help, because it still may not be enough. They may need an additional dose. If it's non-anaphylactic symptoms, they're presenting with perioral edema or the respiratory symptoms, then you can give antihistamines with or without a steroid, and that's typically what our ER will do as well with the non-anaphylactic symptoms. Further management is education 100% with the patients, with the parents, and any other caregivers that may be partaking in their care. And that includes, as I'll talk next, is your schools, your daycares, churches. Anybody that's going to be watching them needs to be aware of these food allergies. And with the parents, you want to make sure that you teach them how to read labels carefully. And I'll go through those details also as far as how things are different, and it's not as straightforward for our common community members to interpret that that food has that substance in it. And the Food Allergen Labeling and Consumer Protection Act in 2006 mandated that all major allergens actually be printed on food labels. The problem is it's not on all food labels for all foods in every area. So it doesn't cover produce, meats, eggs, or poultry, and it doesn't require in restaurants or other fast food restaurants either. Cross-contamination can be an issue, and cross-reactivity can also be issues when it comes to food allergies. With cross-contamination, we've all seen on food items where it says that it's been made in a plant that also processes nuts and peanuts and tree nuts. Or it may say that it may contain milk, or it may contain nuts. Like chocolate bars typically will say may contain nuts, even though it's just your general milk chocolate bar. Like I said, you may also have cross-contamination in restaurants, school kitchens, even your home kitchens, the deli where they process meat and cheese. If you're just there to get the meat, then they may also have a little bit of a dairy substance on it because they're not cleaning the blade or cleaning the surface where they're cutting the meat. Any shared utensils, fried food, they're all fried in the same grease, and so you may have that cross-contamination. An interesting thing that I read was as far as storing your food safely. If you have a child or a family member in the house that has a food allergy, you want to make sure you're storing those safe foods above those foods that have those allergens. It's really more like common sense, but it's hard for us to really imagine if we don't have a food allergy. So if someone has an allergy to peanuts or some liquid substance and you put it on top of a safe food and something falls because children are going in the refrigerator and knocking stuff over, then now their safe food is affected with their food allergen. And then with cross-reactivity, I have a nice little chart here, and this is not every cross-reactivity. It's not 100% certain that if you have an allergy to the birch pollen, you will be allergic to apples and peaches and plums. It's not a 100% guarantee. It just shows that those pollens from those trees will possibly cross-react with pollens from fruits and vegetables as well. And my interesting thing I saw was with the latex. So if you have an allergy to latex, you may also have an allergy to bananas, kiwi, chestnuts, and the list goes on, but mine did not. Effects of food allergy avoidance. So like I said, the #1 treatment for food allergy is avoidance. And so if you're avoiding a certain food, you may have growth problems. And so if you're not having enough calcium or enough proteins, then your growth curves may be affected, especially if there are more than 2 food items eliminated. With milk allergy, studies have shown that they actually have a lower weight percentile and a lower BMI. Then you also have the effects of nutrient deficiency. So if you're eliminating an entire food group, you may be susceptible to nutrient deficiencies. And this is examples of your different food allergens, your milk, soy, wheat, peanut, etc., and what nutrients those products are composed of. So your milk doesn't just have your calcium and vitamin D, it also has vitamin A, B12, riboflavin, phosphorus, and then protein in itself. And so if you're eliminating the entire milk food groups, then you're at risk for developing those deficiencies. Doesn't mean you will, it just means that that's something that we should consider as pediatricians, and also consider consulting a nutritionist to make sure that we're replacing those supplements. With milk allergy in itself, you obviously, as we all are aware, can become calcium deficient, and so you want to make sure that you're giving them supplements or providing calcium fortified foods, and I have a nice chart on those as well. So milk allergy, alternative sources to milk to get those nutrients are your meats, your legumes, grains, and nuts. Milk may actually appear on labels as casein, whey, lactulose, or lactalbumin. And it's also contained in different foods that you wouldn't really think of. Now, when people bake, they typically put milk in cakes and cookies, but you don't really think of milk being in a ground meat or hot dog or soup or really margarine. Yes, it's a cream, but we don't really think of it as being milk in itself. And this is the chart that I mentioned earlier. So an 8-ounce glass of milk has 300 milligrams of calcium, which is 30% of your daily value. Regular soy, just by itself, nothing additional added to it, is only 40 milligrams of calcium and 4% of your daily value. But now that they're starting to enrich your soys and fortify your orange juices and breads, you're getting more of that calcium in it. This is a big, huge chart. I'm not going through all of it, but it's pretty much the same thing that we went over with milk for your egg, your peanut, your soy, and your wheat. So all the different foods that they're found in, the alternative sources of nutrients, and then the others are fun facts that I found on each individual allergy. So with egg allergy, we need to know that egg is found in mayonnaise and meringue. And so if it says that there's meringue in that pie, then there's egg in that pie. And mayonnaise, one of the top ingredients in mayonnaise is raw eggs. So consider that if there's an egg allergy. With peanut allergy, if they use a highly refined peanut oil, it's typically safe for most peanut allergies. That doesn't mean your patient or your child has peanut allergy, go out and use that highly refined peanut oil. Consider it as a possibility, but don't rely on it, and don't expect no reactions at all. And avoid tree nuts because that cross-reactivity between nuts and tree nuts. And then with soybean allergy or soy allergy, the soybean oil is, again, usually safe, just like with the highly refined peanut oil. It's not a guarantee, but it's a possibility. And soy lecithin is safe as well. So the effects of food allergy, you have your nutrient deficiencies. We went over most of the components that are affected. And with milk, if they eliminate milk from their diet, then 48% of those patients do not meet their daily value recommendations for nutrients found in milk. And the interesting thing that I saw was for meat. So for those people that eliminate all meat products, then they're at risk of 72% of not meeting their daily value. And most people will do alternatives like their proteins, their peanuts, their legumes, their beans, their grains. but 72% are still at risk, again with those that don't like veggies. So CMI versus CMA, what is that? So cow's milk intolerance versus cow's milk protein allergy. And so this is what I really wanted to focus on a lot of, because it really plays a major role in the general pediatrician. So cow's milk intolerance is non-immunologic reaction to cow's milk. So this is typically when you think a 1-year-old comes in with diarrhea and mom says he's just not tolerating the food. Is it because he has an allergy? Is it because it's completely unrelated to the food? Or is it because he's just a little intolerant? So these typically present with GI symptoms only. An example is lactose intolerant. It's actually the most common cause of your cow's milk intolerance. These people can usually tolerate small quantities of milk, so a reduced intake is ideal, or they can use those lactose hydrolyzing agents like your lactate milk. This, however, lasts the entire lifetime. They don't grow out of your cow's milk intolerance. It will forever be there, and we'll talk about treatment later on. Cow's milk protein allergy, the actual allergy in itself, is immunologically mediated reaction to the cow's milk protein. So they can present with the GI tract symptoms, the respiratory symptoms, or anaphylaxis in itself. The major treatment for this, because it is an allergy to the protein, is elimination of that protein from their diet. They usually outgrow it by age 5. Like I said earlier, it could be 1 to 2 years old, but they usually outgrow it by 5. So it's something that we can retest later on. We can do a food challenge later on, but we don't have to jump to it. So food protein-induced enterocolitis, or FPIES. So this was under my first chart. It was under the immune-mediated non-IgE category. So it's immune-mediated non-IgE reaction. It's most common in infants and children. It's classified in either acute versus chronic. And it's diagnosed primarily by the clinical picture, history always with any type of adverse food reactions or allergies, and an oral food challenge. The treatment is identify what caused it and eliminate it from the diet and see if the symptoms are improving. And this is just a picture comparing your acute versus your chronic. Typically with FPIES, you will have vomiting and diarrhea are your major symptoms. With acute, your vomiting is repetitive. It's projectile, it's over and over again. It can happen 10 to 20 times a day or more. And your diarrhea is acute with or without blood loss. And so because of these symptoms, because of that repetitive vomiting, they're at risk of symptoms of shock, hypothermia, pallor, lethargy, dehydration. With chronic, their vomiting is more of just an intermittent vomiting. It's usually related to food, but it doesn't always have to be. And their diarrhea is more of the chronic diarrhea, with or without blood. And so this tends to transition to your failure to thrive patients or with weight loss. With both of these, there are some lab variants for your acute versus your chronic. They both will have their metabolic acidosis picture, and they both will have methemoglobinemia, but your acute will have thrombocytosis and neutrophilia, and your chronic will have anemia and eosinophilia. Those aren't very prominent features to decide if it's FPIES. You wouldn't go immediately and say, well, let's do some lab work and come up with the picture. You want to do the food challenge. So another case, 16-year-old male with allergic rhinitis due to pollen allergies. So he complains of an itchy mouth, lips, tongue, and throat after eating raw apples, apricots, celery, and peaches. He has no reactions to apple pie, canned apricots, frozen peaches, or celery in soup. And he has no rash, respiratory, or GI symptoms. So this is oral allergy syndrome. So I'd never heard of it until I started researching all this, but it's actually pretty interesting. So oral allergy syndrome is the most common food allergy manifestation. It's often ignored, but it may progress. It's usually ignored because the symptoms are pretty minor. They may have a little bit of itching or burning around the mouth, a little erythema or edema. You may think it's a little contact dermatitis. It's nothing, no big deal. Or they may even have hives of the oral pharynx. It's associated with fresh fruits and vegetables, not cooked, not canned, not frozen, but fresh. The allergens are actually inactivated by the stomach acid, so you don't really see any systemic reaction. This usually begins in childhood or adolescence, and it lasts a lifetime. More than 50% are associated with those pollen allergies. from the fruits and vegetables. The protein in the fresh fruits and vegetables is heat labile, and I'll go over that next. And you treat oral allergy syndrome by avoiding those fresh fruits and vegetables. And you may consider doing pollen immunotherapy through the allergy immunologist. The diagnosis of oral allergy syndrome is much like all other food allergies, history, and then skin testing to verify the cause. So a 2-year-old develops generalized flushing and urticaria within minutes after eating 1 bite of scrambled eggs. He has a similar reaction to mayonnaise, raw egg touching the skin, and pancakes, but he's able to eat cookies, cakes, and pastas with eggs. So this is another example of a reaction to a protein that's actually heat labile. And so whenever it's in the raw, he has a reaction, but whenever it's cooked down, then he doesn't have the reaction. So the types of food protein, you have your heat labile, your heat stable, and then your variable. So heat labile, there's a significant effect from cooking and freezing and canning it. It degrades the protein so that you have less of an effect. And the heat labile proteins are typically found in your fruits and your vegetables. Heat stable, there's no effect once canned, frozen, or cooked down. You still have the effect no matter what. And these are typically found in your peanuts, your nuts, and your shellfish. And then variable types of proteins in eggs, milk, and wheat. It may be affected by cooking or it may not. So how do you treat it? What do you do in different ages? So age-specific food allergy management. A 3-month-old on cow's milk formula develops worsening eczema and mild wheezing with colds. The patient was changed to an extensively hydrolyzed formula with improvement in eczema and wheezing. So we fixed this kid. So why did they make those choices? So in infants with breastfeeding is your protective and your recommended form of feeding any infant, and it's recommended for at least 6 months. Signs of allergy in an exclusively breastfed infant, you want to consider maybe it's an allergy that mom's consuming. So you want to perform allergy avoidance with mother. They'll pump and freeze their milk, and then they'll do a trial of either an amino acid-based formula or an extensively hydrolyzed formula. And if the symptoms resolve, mom can retry that milk again with milk protein restriction. If the symptoms return, then the infant needs to be changed to formula and avoid breastfeeding. As far as solids go, the AAP recommends waiting until 4 to 6 months to offer solids, and research shows that solids introduced between 3 to 4 months and 6 to 7 months is the ideal window. And within that window, it provides tolerance, but outside of that window, it can promote sensitization. Solids and allergic disease. This is just some studies that show pretty much that evidence is conflicting and inconsistent as far as introducing solids before a certain age. One study showed that 5 studies showed an association, but 4 showed no association between introducing solid foods before 4 months old and eczema. Then the other study showed no relationship of wheezing and solid foods. And then the last study that I saw in this article was no association between solid foods and wheezing or rhinitis at all. So again, it's another study about food allergy that we need more research on and more studies on. And this just tells you a little bit about the maternal diet and risk. There was a recent article out in February about introducing peanut allergies and eating peanuts during pregnancy and during nursing, and pretty much all that, again, is inconclusive. And the NIAID that I mentioned earlier recommends no preventative food avoidance during breastfeeding. And one of these studies, it shows mothers without peanut or tree nut allergy and a higher peri-pregnancy consumption have a lower risk of infants developing allergies. This is very confounding to me, and I found it a little humorous because obviously a mother that doesn't have a peanut or tree nut allergy, the child is at a lower risk. A mother that has that does have an allergy, the child's at a higher risk in itself. We showed you that with genetics. Also, if you have an allergy, you're not going to be consuming nuts during pregnancy. So, not very supportive. So with infant formulas, I'm not going to go through everything, but we know that there's cow's milk and soy milk protein formulas. There's partially hydrolyzed, extensively hydrolyzed, and then your elemental or your free amino acids. When considering a food allergy, they typically will start with the extensively hydrolyzed formulas, your peptiment, elemental, Nutramigen, or progestamil. These formulas, the proteins chopped down into pieces, it's better tolerated, but it may still trigger an allergic reaction. Patients About 3 to 5% will still have a reaction to the extensively hydrolyzed formulas, so that's when you would switch to the elemental, which is your Neocate and your Elecare. So cow's milk allergy versus cow's milk intolerance. I'm almost done, I promise. So cow's milk allergy, you don't want to do soy products. It's a possibility. There's that 25 to 50% cross-reactivity between soy milk and cow's milk. So ideally, we would avoid it and go more towards your almond milk and your rice milk. If they're breastfeeding, you want to do the trial and possibly do cow's milk elimination. And if those fail, then you do formula extensively hydrolyzed. If that doesn't work, then your amino acid-based formulas. They may outgrow it by 1 to 2 years old, or it may take a little bit longer. They may have it until about 5 years old. There is no firm timeline. With cow's milk intolerance, this is your lactose intolerance type. Soy products are okay. There's no cross-reactivity. Lactose-free products are okay. With your cow's milk protein allergy, lactose-free is not okay because there's still that whey protein in it. With cow's milk intolerance, it's not outgrown. It's a lifelong process. And Pediatric is lactose-free. Pediatric has whey in it, so it's not okay if they have the allergy. But if they have the intolerance, you can still do Pediatric once they get to that age if they need it. In school-age children, the main thing here is just prevention rather than your dietary changes and your nutrient deficiencies. You want to educate the teachers, the bus drivers, the coaches, maybe even form a health plan if a food allergy does occur in school so that they know what to do and they know to prevent it. With high school, the main problem with high school-age children is they're risk takers. And so if their best friend is eating a peanut butter and jelly sandwich and they're highly allergic to peanut butter and it really looks good and smells good and they can do it, why can't I? Then they may actually take that risk and try it. And so high school age students have the highest chance of having anaphylaxis and food allergies. So in summary, the adverse food reactions are classified as your immune and your non-immune, and then that's broken down further as well. Your food allergy is immune mediated, and the symptoms can be GI, respiratory, skin, or anaphylaxis. It's transmitted through inhalation, skin, or ingestion. Diagnosis is by history, your skin testing or your IgE testing. If they have severe or poorly controlled atopic disease, consider food allergies. The major treatment is avoidance. You also want to educate patients and parents on avoidance and the treatment upon exposure. Provide those 2 EpiPens. The nutrients affected by food avoidance and alternative sources, we talked about those. Oral allergy syndrome primarily affects the oropharynx, and it's related to fresh fruits and vegetables. Cow's milk intolerance is non-immunologic. It's lifelong. They have GI symptoms only, and soy is typically okay. Cow's milk protein allergy is immunologic. They may outgrow it by 5. GI, respiratory, and skin symptoms, and possible soy cross-reactivity. So these are just some resources for families if they need any handouts on food allergies, what to do, what to avoid, and then all of my resources. Thank you. Any questions? Any questions? Yes, Dr.
I got one question. Can you stress how important it is that they go in anaphylaxis to get the EpiPen? Will any of the schools in this area let the kids carry it? Because we both know that if it's sitting down and the school nurses and she's in the bathroom or she's sick that day or they lost it, there may be a way of getting it. So what's the local scene?
That I'm not quite sure. It is a sharp device, so I don't know if they would allow it to actually be on the patient's self, but we could even possibly consider the teachers having it at their desk, especially if it's a small classroom. You know?
Teachers multiple times.
But the school nurse is only there maybe a half a day.
Yeah, that's what.
But all we can.
So, and I think teachers are.
I'd like to make a simple little comment about lactose intolerance because I spent 3 years of my life majoring in this. There are 3 ways you can become lactose intolerant. The very first one was Holzler and Grant, I think it was 59 or 60, and that's congenital lactase deficiency. That is for life, very, very rare. It's very common to have familial. The usual onset of that is, the only real source of this is mammalian milk, and it doesn't come on until they stop nursing at the breast. And so rats at stage 21, I can tell you, is in almost all other animals, except sea lions. They're the only animal that don't make lactose. And so most of these will come on after 3 to 5 years of age, often around 8 or 9, rare before around 5. That's when we can export our surplus Wisconsin milk to starving kids and not make them worse. Both of those are lifelong. If you've got it in childhood, the overwhelming cause of it is going to be intestinal disease that interferes with microvilli, and once the basic disease gets better, they do that. The classic is a severe gastroenteritis. Rotavirus is notorious because that works by lysing the enterocytes. Any patient who's got celiac disease that's symptomatic, they may have some minor symptoms of lactose intolerance, but as once they go on a gluten-free diet, that goes away. And usually that occurs within a week or so. So you got to be careful on which is lifelong and which isn't. I keep going back to Porgy and Bess, the operetta. Now it's considered opera. There's in there this little song, ain't necessarily so.
Thank you, Dr.